Hi, everyone. Thank you for joining. In the interest of time, I'm going to get started right at 9. That way we can make sure we stay on schedule today. We're very excited to have you join us for our first national patient meeting. Next year, hopefully it'll be in person, but this year we're glad you can join us virtually. My name is Claire Stevens. I'm the Director of Operations for the USTMA. So a lot of you may have seen me on Facebook or gotten emails from me. But I just wanted to welcome you all today and give you a few little tips about Zoom. At the bottom of your screen, you should see something that says Q&A within the control panel there. And that will allow you to ask questions throughout the time that we're doing presentations. Each of the presentations, other than the breakout sessions, have allowed for about a 30-minute block of time afterwards for a question and answer session with a variety of the hematologists and other physicians or PhDs that we have joining us today. So if you want to submit your questions, please use that Q&A function. It will help us keep track of them. There's also a chat function that will allow you to message the panelists if you have interest there, but you can also chat with each other during the session. If you have been waiting a long time to meet someone else with TTP and you happen to make a bond, you're able to chat with other participants as well. Certain portions of the meeting will be recorded. The breakout sessions will not be recorded unless they're hosted on the main patient link. But that way we'll be able to have those videos for future reference. And that way people who aren't able to attend the meeting today will still get the benefit of being able to watch the recordings. So with all that being said, I'm going to go to our next slide and introduce Dr. Mazepa, who will be giving us our welcome.
Well, good morning, everyone. I hope everyone is having a wonderful morning so far. We're very excited to get started here for our very first patient meeting, which we first started brainstorming probably around a year ago. So it's really thrilling to have everyone join us for this very first patient meeting, which we anticipate will be the first of many. Like Claire said, my name is Marshall Mazepa, and I'm a hematologist here at the University of Minnesota. Though I wish, as Claire has said, this was in person, and we certainly are planning to have a meeting like this in person next year. We are hoping that doing this virtually actually maybe extends the reach a little bit, and we're still really excited to pull this meeting together, both for an opportunity for the patients to meet one another. So you have, I think, some of that camaraderie of meeting another person with this rare disease, but also getting to know us as providers who have a great deal of passion for this disease and making an impact for our patients. I have to thank my collaborators who've worked so hard over the last several years as we've put together our research group, who've taken time out of their Saturday to join us and hear from you, the patients and supporters. So I have to thank them. And I also have to thank our sponsors, Takeda and Sanofi, who've supported us for this meeting. So I wanted to start today with a little bit of background about the USTMA consortium. You'll hear more about this group throughout the day. When I was completing my hematology training and I became very passionate about helping patients with this disease and making an impact for them, I was really surprised that there was not really any infrastructure, there's no organization around the country to help meet the needs of patients. But what I saw was an opportunity to bring together my friends and colleagues who shared my passion for this work so we could do better for our patients. And so with Dr. Spiro Catalan at Ohio State University, who you'll hear from next, we started to organize our research efforts, And over the last 5 or 6 years and ago, we have slowly put together this USTMA consortium. And so we now are trying to reach beyond just physicians, researchers, to include you, patients, and your supporters to help guide treatments in our research efforts, because in the end, it's really the patients that we're all working for. Claire, you can advance to the next slide. So here's what I hope you get out of the meeting today. I hope you get an opportunity to be acquainted with the USTMA and our many investigators. I hope you get a chance to meet other people with this disease and try to bring a sense of community for people with this rare disease. I hope you get an understanding of how research is working to benefit people with this disease. And I think probably even more importantly, how you can participate and guide this effort. We really need your input because the research isn't meaningful unless it really impacts our patients. And getting a standard of future and current treatments for the disease. Go ahead and advance, Claire. So here's how the day will break out. So these are times in US Eastern time. As you can tell, we've started promptly at 9 a.m. So thanks, Claire, for keeping us going right on time. Around 9:30, this first talk will wrap up, and I'll be joined by a few investigators from the USTMA for some panel discussion. And you'll see we've incorporated lots of time for discussion today because we realize there are lots of questions out there, and we want to try to answer for people. So Dr. Catalan, who helps direct the USTMA with me, will then talk about preventing relapse and how we can strategize, how we can prevent what obviously we know weighs on patients and weighs on us, which is relapse. And so how we can do that and how we're working to better understand relapse. We'll have some panel discussion again at 10:30, and then at 11, Dr. Chaturvedi from Johns Hopkins will talk about TTP in the brain, which is a very active area of research for her specifically and as a group. And again, a panel discussion. And then we'll break for lunch at 12 Eastern. Go ahead and advance, Claire. Then we'll start the afternoon sessions. At 12:50, we'll have a 10-minute presentation from one of our sponsors, Sanofi, about their new medication for TTP. And then we'll start our breakout sessions. At 1 p.m. Is our first breakout session. If you want to hear more about congenital TTP, you'll stay here on the main link. If you're interested in meeting with other patients and investigators in the USTMA, you'll follow a separate Zoom link in your invitation to join Coping with Chronic Disease. And we'll come back together at 1:45 to hear a really interesting discussion from author Joanne Jacobson about her a recent book on her journey with TTP. And then at 2 p.m., we'll have a second breakout session. Stay right here with us in this main Zoom meeting to hear about women in TTP. And then if you want to join our panel, our panelist for a Q&A session called Ask the Hematologist, you'll follow again a separate Zoom link in your invitation. At 2:45, Dr. Darla Lyles from the East Carolina University will give us an introduction to research, how research is different from regular clinical care, so you have some understanding of what it means to participate in research. We'll also have a little panel discussion after that talk. And at 4 p.m., wrapping up today, we'll have a talk from Dr. Jim George on building a TTP community. And it's truly a pleasure to have Dr. George join us because he is, simply put, one of the world's experts on this disease and really inspired us to really put this national meeting together based on his work putting together a patient meeting many years ago in Oklahoma. So I think that's a great way to end the day. All right, go ahead and advance, Claire. So what I wanted to do with this talk today is really set the stage so that we're all on the same page. TTP is a confusing disease, and so the terminology that you may hear from different doctors can be confusing, and it is confusing to doctors, so that doesn't help either. So here's a little bit of the history of the disease, and I think you'll understand why the terminology has gotten confusing. So when TTP was first described about 100 years ago, it got this very long name, essentially a Latin name describing what we saw, because we didn't know what was causing this disease. So TTP stands for thrombotic thrombocytopenic purpura, and you can tell, given this long name, that's why we stick with TTP, much easier to say. So for a long time, up until the 1970s, we really didn't know what to do for people with this disease. And in the 1970s, the first attempts at plasma exchange and plasma therapy were tried. And then in 1991, we had two very important landmark discoveries in TTP. First was that the first large randomized trial was conducted in Canada that showed that plasma exchange was better than plasma transfusion. And at the same time, doctors from Johns Hopkins University published their experience that showed prednisone was beneficial to patients with TTP. And even in a small group of their patients who had milder symptoms from TTP, could actually go into remission without plasma exchange, with just prednisone. So that started to give us clues that there was something wrong with the immune system, since prednisone is a medicine that pushes down on the immune system. In 1998, another big discovery in TTP was the discovery and description of ADAMTS13 as the cause of TTP. In the 2000s, rituximab or Rituxan was introduced and small trials were completed. And then just in the last few years, the trials of caplacizumab were started and eventually led to approval of the medicine by the FDA and European regulators for this disease. All right, please advance. All right, so TTP terminology. Again, this is where this confusion sometimes comes about. So TTP-HUS was the first term used to describe a syndrome. And when we say syndrome, we're describing a set of symptoms and laboratory findings to describe the disease. Now, TTP refers to a disease caused by ADAMTS13 deficiency, and the syndrome or family of diseases is now called thrombotic microangiopathy. Hence, you can tell this is where the name for our organization came from. So thrombotic microangiopathy is a family of diseases with similar findings, and TTP is the most common member of that family. And then within TTP, there are two forms. Immune-mediated has recently replaced the term acquired TTP, so you may hear that term as well. And that's the most common form by far. Congenital or hereditary TTP are the same disease. Those terms can be used to describe people who are born without the ability to make ADAMTS13, and that's more typically diagnosed in childhood, or sometimes is diagnosed for the first time in pregnancy. All right, please advance. So you can see here a representation of the thrombotic microangiopathies as a family. Probably at least 50% or so, around half, seem to have other causes. What I mean by other causes is that they mimic TTP. They have similar laboratory findings of low platelets and broken up red blood cells in the body, but they're caused by something other than ADAMTS13 deficiency, and we really don't understand what causes these. So for example, this can happen after a bone marrow transplant. It can happen due to certain drugs. It can happen related to lupus. It can happen due to pancreatitis, and the list goes on. And so this is an active area of research trying to understand simply what causes this. I would say the other half is a mix of TTP, which is by far more common, and then a similar disease called atypical HUS, which is a genetic disease that does tend to show up later in life and causes more injury to the kidney, so is also commonly managed by kidney specialists. Okay, next slide. So let's get into a little bit of how the disease works, because again, I think understanding this is an important part of understanding treatment and how the disease affects the brain. It is a complicated disease, so I'll try to go slow and explain how this works. So in both forms of TTP, patients have a deficiency or low level of ADAMTS13. In congenital or hereditary TTP, patients are born without this enzyme. In immune TTP, again, the most common form, patients develop the disease later in life. So for most patients, this disease starts with a mistake in the immune system. Okay, if you could advance, Claire. Great. So you can see here, our immune system is really the problem that starts this disease in immune TTP. Our immune system has a tough job. It has to figure out who's an invader and who's self. And unfortunately, there are times when the immune system simply makes a mistake and starts attacking our own body instead of an invader, like a virus or a bacteria. And this means that this most common form of TTP is an autoimmune disease, putting in the family of diseases like lupus, multiple sclerosis, and rheumatoid arthritis. I've shown in this first picture here, the immune cells shown in blue are making proteins called antibodies that look like a Y shape. Obviously, this has been in the news a lot lately around the coronavirus. And these proteins have a lock and key fit for their target. And in this disease, the antibody attacks the protein in our blood called ADAMTS13. If you could advance, Claire. Great. So once the body starts making these antibodies that attack ADAMTS13, we develop low levels of protein in the blood. And as a result, we start developing these long stringy proteins, here I've shown in green, called ultra-large von Willebrand factor. And when this happens, these strings start clumping platelets together. I like to think of this like Velcro and tennis balls. Picture a big string of Velcro in the blood. And now that Velcro starts clumping the tennis balls together that float by. So now these big clumps of platelets get stuck in the tiny blood vessels in the body and cut off blood to the organs. If you could advance it, thanks. For reasons that we don't understand right now, it appears that the brain is most susceptible to this problem, and Dr. Chaturvedi will talk more about this today. So most people who have this disease will have some sort of thinking problem when they get sick with TTP. We also know the disease can affect the kidneys, but generally less so than the brain. And we can also see that there is damage to the heart during a TTP episode, though it's generally quite mild and maybe have no symptoms at all, and low and essentially no long-term damage to the heart. All right, go ahead and advance the slide. All right, so now that we understand how the disease works, how do we use this understanding to treat the disease? So you can see here, I've shown our plasma exchange machine that you're all quite familiar with. And we use plasma exchange to temporarily replace the missing ADAMTS13 from blood donors. And as we remove the plasma from the patient, we also remove the antibodies that are in the blood. If you can advance, Claire. We also use medicines like prednisone and rituximab to calm down the immune system from making more antibodies. And you'll hear more again about this today from Dr. Cataland, about how we use these medicines, and there are opportunities to learn more about which medicines work best for certain patients. And then more recently, there's a new injectable medicine called caplacizumab that's been approved for the treatment of TTP. This medicine blocks the tennis balls from sticking to the Velcro. So like plasma exchange, it's a temporary fix. But both plasma exchange and this medicine are important to stopping the blood clots and damage to the body. So again, you'll probably hear some more about this from Dr. Cataland. Great, thanks, Claire. We talked about treatments for TTP. It's really important to think of these treatments as really two categories. First, we use treatments to get patients into remission, shown in the green box. So those tools are plasma exchange and caplacizumab. Again, the plasma exchange is done once a day till the platelet count is normal. And caplacizumab is a new medicine. And so doctors currently, I would say, have variable comfort with this medicine. And the way it works is it's given each day after plasma exchange and then continued at home for 30 days after you leave the hospital. The other types of treatments we use are medicines to keep you in remission. And the goal of these medicines are to calm down the immune system to help you stop from making more antibodies that cause the TTP. Most commonly, these are prednisone for several weeks, and rituximab, which is given as a once-a-week medicine for 4 weeks. And then there are lots of other medicines that are out there that are sometimes used to treat the immune part of this disease, but are less commonly used. Go ahead and advance. So we have lots of room for improvement in TTP, and here I've listed some of the big questions we still have to answer. We want to know, can we replace plasma exchange with something better? Prednisone, it works, but it's toxic, and can we replace it? Is rituximab actually better than prednisone? Is it better in everyone? If I relapse with rituximab, is it worthwhile to get the medicine again? Why is it that some patients have persistent problems with thinking and memory and emotions? And how do we treat or prevent this? And is there a way to predict and prevent a TTP relapse? So you can see this list of questions could go on, but you can see while we have improved our treatments over the years for TTP, there's still lots of room for improvement. Go ahead and advance, Claire. So here is an example of how organizing our research efforts in the USTMA over the last few years has started to turn up some interesting new findings as we work towards our goal of making TTP treatments better. So over the last several years, the USTMA consortium has put together a database that contains the demographics, treatments, and TTP episodes from about 800 patients, reaching back to sometimes as far as 30 years ago. And we wondered whether the addition of rituximab to prednisone benefited our patients, or probably more importantly, whether there might be some patients who benefited more than others, and this might help us choose our treatments better for our patients. Certainly rituximab is very commonly used, and so we wanted to try to understand how well it's working. All right, go ahead and advance, Claire. So here you can see the sites that participated in this first project from the USTMA consortium. And since then, we've added several new sites as well, which is really exciting. So here, here's how we analyzed the data. So what we did was we looked at all the possible aspects of our patients and whether any of these predicted a long remission after rituximab was added. After this was done, we found no differences, say, between men and women or between different age groups at the time of diagnosis, and you can imagine going on from there. What we found was the only important predictor was that ancestry matters, or our ethnicity. And this is important because it suggests a genetic component to the disease that we never knew about before. So in this diagram, the cartoon people in red are the patients who have relapsed, and those are in blue who are still in remission. So you can see that in patients who are African American, that we compared those who received rituximab to those who just got prednisone alone. And you can see at 5 years that there was no difference between those patients who got rituximab and those who got prednisone. So you can see about 6 out of 10 patients had had a relapse, no matter which treatment they got. But we did see a difference among people with Northern European ancestry. So those who got prednisone had the same likelihood of having a relapse as our African American patients. You can see, again, 6 out of 10 had a relapse at the end of 5 years. But those who got rituximab were much less likely to have a relapse at 5 years. In this group, only 2 out of the 10 patients had a relapse by 5 years. So it brings up really important questions about why there might be a difference between 2 ethnic groups. We wonder whether there's something about the medicine working differently. Is there something different about the disease? What about genetics? Could there be something genetically different that's between the 2 ethnic groups? So really, we've gotten some answers, but from this kind of study, we expect now we have some new important questions to try to answer about how do we improve upon this, particularly for our African American patients or patients who've had a relapse quickly after rituximab. Go ahead and advance, Claire. So what we're really talking about is tailored treatments or using information about the patient's disease and the individual patient to match the patient to the best treatment. We want to know, can we predict why and when certain patients will relapse and prevent this? Again, you'll hear more from Dr. Cataland about this. And can we understand why many patients have lingering effects of TTP so we can treat and prevent these? Go ahead and advance. So how do I participate in research studies now? So we encourage you to join our mailing list. You can find us online at our website. You can also importantly find information about participating in clinical trials, which we generally consider a clinical trial, a study of a new medicine. You can always find more information at this government website called clinicaltrials.gov. So for example, right now there are 2 studies going on of a new medication called recombinant ADAMTS13, which is essentially the missing protein ADAMTS13 that's highly concentrated and synthesized in a laboratory instead of coming from the plasma of donated blood. So there are 2 ongoing studies that are listed on clinicaltrials.gov. There is a phase 2 study that is going on right now in acquired TTP, and a phase 3 study of this protein in congenital TTP. You can also see the US sites that have the study open. So for example, I listed in the congenital TTP trial that there are sites in Ohio, North Carolina, Oklahoma, and Atlanta, Georgia. Go ahead and advance, Claire. You'll hear more from Dr. Chaturvedi about how we're studying the effect of TTP on the brain over time. And there are 3 studies ongoing right now that are smaller studies. We in the USTMA have an ongoing study about how the brain is affected in remission, open here in Minnesota at Ohio State and soon to be open in Oklahoma. Dr. Chaturvedi has a study of MRI changes over time that's open at Johns Hopkins. And Dr. Dee Terrell's REACH TTP study, and she works at the University of Oklahoma, but this is actually a study that's done over the phone. So you don't actually have to travel to Oklahoma to participate in her study. So I'm sure you'll hear more about these today. And then we're also studying the real world effective treatments on TTP episodes. What we're trying to do is expand on the findings we made from the retrospective study, so the collection of data going back several years ago, to try to, again, match treatments based not just on, say, ethnicity, but are there other biological markers that might help us to determine which treatment is best for which patient. So that's an ongoing study throughout the USTMA. Go ahead and advance. So to summarize, you can see TTP is a complex disease, and the terms have changed over time, which has made this a bit confusing. Remember, there are two forms. One that's more common called acquired or immune TTP, where we have to replace both the missing enzyme and give medicines to affect the immune system. There's a congenital or hereditary form of the disease, which is very rare, often diagnosed in childhood. Now, this disease is not treated with drugs that affect the immune system because what's important is replacing the missing enzyme. In immune TTP, treatments are generally given to get patients to remission, achieve remission with a normal platelet count, and then other drugs to suppress the immune system to keep patients in remission. And again, patients have a very important voice that needs to be heard to help guide our treatments in TTP. And we welcome your input on our research priorities to our website and Facebook page. So thanks, everyone. And I think at this point, we'll then have our panelists join for some questions and answers.
All right, I've promoted our panelists, so they should be able to turn on their video and unmute themselves. It looks like we have 4 questions in so far. The first one is, can you participate in clinical trials if you are in remission from TTP?
Tell you what, I'll go ahead and get started. Clinical trials always set specific inclusion and exclusion criteria, meaning that certain trials will allow specific patients into the trial based on what they're trying to study. So, for example, if the trial is of a new medication to get patients into remission, they wouldn't necessarily allow patients into the trial who are already in remission. But on the other hand, for example, our study that's trying to understand the effect long-term of the disease on the brain, we only want patients to participate in that study who are already in remission, because we know that the disease, when it's flaring up, is definitely affecting the brain. So it really all depends upon what the rules are for the trials. And you can see on clinicaltrials.gov what the rules are for participating in those trials. So this is really a great resource for people. So it really just depends upon on the specific trial.
All right. The next question here is, Laura wrote in, she said, what about if you did both? I'm unsure what both she's referring to. I assume it would be like caplacizumab as well as steroids, but I'll let her write in and clarify the question. There was another question here that said, I noticed there are no Florida sites in the research registry. Can Florida be included in the future? And I know we have an exciting update about that. I don't know who wants to take it.
I can jump in and say, yes, indeed. We, in fact, do have an investigator now at located in Miami. Dr. Messias there is recently joined the Baptist Hospital in Miami, and she's participating today in the Women in TTP small group. So you'll have actually a great opportunity to meet her then.
Okay, perfect. And yeah, we did get clarification. So it's, what if you did both forms of treatment, steroids and caplacizumab, or rituximab and caplacizumab? So the use of multiple treatments there. Who other than Marshall wants to talk?
I can take that one.
Yeah.
So when we think about these treatments for TTP, this is a really important question. So drugs like caplacizumab, what they do is prevent those little clots forming, prevent the platelets getting used up in the clots, and prevent the organ damage that happens because of these tiny clots in TTP. What caplacizumab doesn't do is fix that immune system response that has led to the TTP in the first place. So it's actually really important to use it along with an immunosuppression medication such as steroids and rituximab. So caplacizumab essentially would protect someone against having more acute TTP while these other medications are working on your immune system to calm it down. I hope that answers the question.
Yeah, that's great. I should have mentioned that in the talk that we typically do treatments from both of those categories, both treatments to reverse the effect of the low ADAM-TS13, but then also treatments to push down on the immune system. The tricky thing about the immune system is that most of our medicines don't work very quickly. Prednisone probably works the fastest, but it doesn't work very quickly. It still probably takes several weeks to really start to see its effect.
Okay, so another question is it possible to now join the clinical trials for the recombinant ADAMS-TS13?
Can I take this question?
Yeah.
So currently there are 2 clinical trials that are utilizing the replacement of ADAM-TS13 in the form of recombinant enzyme. And clinical trials are open at certain sites, and just like what was mentioned by Dr. Mazepa, and if you reach out to clinicaltrial.gov and you type TTP or ADAM-TS13 replacement enzyme, you'll find the 2 trials, and you can look at the sites near you that you can reach out to them and possibly get enrolled.
So essentially the best way to do that would be to find a site, reach out to them, and then determine whether or not you meet the qualifying criteria to be able to join the trial.
Correct.
Can I also add something here?
Sure.
So, for acquired TTP, which is more common, the recombinant trial was intended to be used along with plasma exchange to treat acute TTP. So you would potentially not be eligible if you were in remission, but you would be eligible if you were having acute TTP, which makes it a little bit more challenging for the immune-mediated acquired TTP. For congenital TTP, yes, you'd have to contact the site. That's on the list.
So
I
another.
think I was going to add to what the others have said. I think if you don't know which sites are open, I think the easiest is to look at clinicaltrials.org, and you would find all the sites that have the study open. Some of them are open and close at different times. So that's probably the best way to initially find sites that are close to you.
So while we're on the topic of recombinant ADAMS-TS13, there's a question. Is it already being used as a treatment somewhere in the world, or is it still in trials everywhere? Are you guys aware of anywhere where it's approved or anywhere where it's being utilized as a treatment?
I think so far it's under clinical trial. I'm not aware of the site where they are in that training.
Correct. Yeah, I'm only aware that it's still only available in clinical trials.
Yeah.
Okay. So are you guys seeing, what are you seeing as the long-term functionality with those with TTP?
Who do you want to take this, Claire?
All right, I'll start with this. I would say it's variable. So it all depends on what the initial presenting symptoms are and which organs are impacted. And so as Dr. Chiravuti will talk about later on, and I think Dr. Mazepa also did mention, TTP can affect several organs. So it can affect the brain, it can affect the kidneys, and in some cases, it can even affect the heart. So it really depends on whether or not it impacts a big organ significantly. There are certain patients who present and the only findings are really just blood count abnormalities. And so for patients who present with just blood count abnormalities, typically, if they do respond to the treatment, the blood counts improve and they feel better. And they may not necessarily have a long-term symptoms. But for those, especially those who get brain involvement, they may have neurologic symptoms that may persist, such as numbness, tingling, sometimes even confusion. And then for those who have kidney involvement, they may have their kidney function not come back to normal. So it really all depends on which organ is impacted at the time of presentation. But a significant portion of the patients do go back to relatively normal life.
And I'll just add that I think one goal of our small study that's going on right now is to try to understand what proportion of patients do have some of these long-term effects from the disease. Because it appears, at least from our practice, seeing patients, that there are some patients who seem to have essentially no long-term problems from the disease, whereas others have major impacts on their life. And so I think first we need to understand what is the split here? What is the proportion of patients who have problems, number one, and then trying to understand how these change over time. I think the other really important point that we shouldn't overlook is how the stress of this disease impacts people long term. Because right now we don't have great tools to predict when a relapse might happen. And so, we hear this over and over again, and we express our sympathy that not knowing when the next episode might happen, and worrying about what their platelet count is doing, and worrying about, am I going to get sick and have a major illness, that really weighs on people. And even though that isn't a direct effect of the disease, it's a really important part of this disease, and that unpredictability is really scary. So we understand that, and I think that's an important point we need to acknowledge. So that's another part, and I think we'll hear more from Dr. Cataland on this about, we think it's really urgent to try to figure out, are there new tests that we can use, strategies that we can better understand when a relapse might happen so we can do something about it. Because medicines that affect the immune system have other side effects, have other consequences. So we need to try to time our treatments well. So I won't steal more of his discussion, because I think there'll be more to talk about that later. But I just did want to mention, we recognize that the stress of the disease is an important long-term effect too.
Okay. Speaking of long-term effects, is it normal to have things like joint pain or fatigue? Do you guys see your patients bring those up to you, or do you know anything as far as how TTP long-term effects manifest themselves? Do you hear about joint pain or fatigue?
I can try to take that one. So these are symptoms that I've had a lot of patients report to me in clinic, that they're not feeling as good as they used to, and many of them describe aches and pains. What has been a little bit challenging is trying to figure out what component of this, if any, is related to TTP and its sequelae, and whether there could be something else going on, because I think that is one of our priorities, is to make sure we're not missing something else. For example, people that have had an episode of TTP, the prevalence or the incidence of diagnosing them with another immune disorder is actually a little bit higher. So I'd want to make sure that they don't have a lupus-like condition or some kind of arthritis going on. However, there are people that come up clean on all of these tests and still seem to have these, impairments. And sometimes this can be part, I think, of the impairment in functionality that comes after TTP in a small number of patients. And it's real. A lot of patients have been reporting it. I'm curious to see what my colleagues have found in their clinics.
Yeah, I have to say I do absolutely agree with you. I've had several patients had what's almost like a chronic fatigue-like syndrome, where you don't really know what's really causing it after exhaustive testing. And so in those instances, it can certainly be attributed to the TTP, but you're right in that we still don't really understand that very well and have a very good sense of what are the number of patients who actually ends up with such symptoms.
And I will add there that if these symptoms like joint pain are coming along with things like joint swelling or rash, then perhaps an evaluation for other immune disorders is indicated, because there is a fair number of people that will get another diagnosis that can be treated.
This patient was diagnosed in 2007 with HUS-TTP, and they weren't sure if they were Adams TS13 deficient. What would they be able to do now to confirm the TTP diagnosis or determine if there was another cause?
Well, thanks for the question, Heather. That's a good one. I think you may want to start with asking your hematologist oncologist. If you can't get an answer there, then one option is to go to a research institution, an academic medical center near you, because I think that's probably it may be that you need more testing to try to figure out exactly what the cause of the syndrome was. Now, sometimes we can detect the presence of low Adam TS13 even years after an episode, because we do know that in remission, the enzyme levels go up and down. So that could give us a clue as to the diagnosis. The easiest time to make the diagnosis is when you're acutely ill, but we can sometimes clarify the diagnosis in remission. So I would say start with your doctor and see if you can get some clarification. And then if there's still plenty of questions left, then trying to find your local university hospital might be the next strategy for you. I don't know if others have thoughts.
Yeah, I think the only thing I would add to that is that I think that's the right start, is to go back to your primary hematologist that treated you. But I wouldn't be sort of too surprised if they don't have a clear answer for you. And the reason is that in 2007, I believe you said, right? Depending on where you live, your doctors may not have had readily availability of the tests to distinguish between TTP and HUS. And so it may be that they went on the symptoms and the lab abnormalities that Dr. Mazepa described and treated you as such. And so, especially if this far out, your labs are completely normal and your kidney function is fine, they may not necessarily be able to tell you, because with the immune-mediated TTP, if the antibodies or the inhibitors are completely gone, we would expect your Adams TS13 level to be normal. And so if that's the case, they can check it, but it may not necessarily give you a definitive answer.
Has there been any research about blood type and the frequency of TTP?
Yes, there has been a fair amount of research on it. There have been several studies that have been done trying to figure out if TTP is more common or presents perhaps in a more severe way in someone with a particular blood group. And this comes from the fact that we do know that people with certain blood groups, such as type O, may have less von Willebrand factor levels at baseline, so maybe they won't get TTP as much or as badly. However, the majority of the studies did not find that association, so it doesn't seem to actually bear out in studies.
That's right. I should say in our large database that we didn't collect information about blood type, so we don't know whether that has any impact on, say, our current findings. But it is an interesting question.
I am going to leave the next question for Dr. Catalan's talk, just because we're running out of time here, and it has to deal with the severity of disease and why certain people have one episode and other people relapse frequently. The next one is, in the UK, caplacizumab has not been approved, I expect due to cost. What would your argument be to support its approval?
Yeah, I think that's a challenging one because we don't operate in the UK system. However, we do have contacts in the UK, and we may be able to reach out to you by email with an answer. I think it just is really hard to answer without knowing the intricacies of the UK system. So if you can reach out to us through our website or to Claire's email, we can work on an answer for you.
So this one has to do with the continued use of prednisone. Would continued use be more harm than good? Could the cure be more damaging? So why do you not use prednisone for long periods of time at high doses?
So I can take this. So the chronic use of prednisone, just like using prednisone long term for any inflammatory condition, it has its own side effects: insomnia, muscle pain. It can cause bone problems and can cause salt retention and high blood pressure. That's one of the reasons we don't like to use prednisone long term.
I'm sorry, Dr. Caladonna. I'm having a really hard time hearing you. I don't know, is anyone else?
Now, we can just clarify. He was saying that there are some long-term side effects from prednisone and listed some important ones, like weakening of the bones and skin. It suppresses the immune system. And so it's a very useful medicine because it works quickly. Of the medicines that suppress the immune system, its main advantage is how fast it works. But it's really a good short-term medicine, not a great long-term medicine. So in general, I think you've hit it right on the head with your question, really, is that the long-term risks are too high compared to the benefits. So we generally try to get patients off this medicine as soon as possible because of that.
Okay. Here is another question. There's a few questions that have to deal with relapse, and I'll leave those for Dr. Cadlin. So this patient was diagnosed in 2019. They were given fresh frozen plasma, whole blood, and fake plasma. Is there a difference between fresh frozen plasma and fake plasma? And this was a severe case.
I wonder if
I don't necessarily think there's a difference. I think it's probably octoplas.
Yes.
That's probably, so it's plasma, but it's just treated and prepared differently, but it's still plasma. So, yeah.
Yeah, I think in terms of when we do the plasma exchange, when we give back the fluid that we're taking off plasma and giving back other fluid, there are really three options. First is to give back frozen plasma from blood donors. The second is to give back this medicine called Octoplas that Dr. Aqua was talking about, which is what's called pooled plasma. So multiple different blood donors have their plasma mixed together, and then it's treated with chemicals to destroy viruses. It's this plasma is frequently used in Europe, less frequently used here in the US. It does tend to be beneficial in patients who've had severe allergic reactions to plasma. Sort of say I can say at my institution, we generally try to use it for those patients. And generally, it's still plasma, but it's multiple blood donors, plasma mixed together and treated with chemicals. And then the other option is something called albumin, which is just protein from blood donors mixed with salt water. So those usually comes in bottles. And what's different about that medicine is it's clear, like salt water, whereas plasma is yellow in color. And so that doesn't have any ADAM TS13 in it. is sometimes used as part of the treatment for TTP, but generally isn't used as the full plasma exchange protocol. But many institutions use it as part of the treatment. So it may be a combination both of plasma and of this albumin solution.
Okay. Let's see here. So this patient is wondering if inflammation and the propensity of, if there's a relationship between inflammation and TTP relapse. There were findings that increased inflammation in the body would bring on a relapse, and would an anti-inflammatory diet be beneficial to help prevent a relapse?
Would you like me to take that, Claire?
Yeah, how about?
So I'm going to start with saying that whoever has asked this question has hit on a very pertinent issue about TTP, is that we don't know all of the factors that lead to relapse. What we do know is having low ADAMTS13 increases your risk, but that's certainly not the whole story, because we've all seen patients who have really low ADAMTS13 and either never have a relapse or take a really long time to have a relapse. So there is the thought that there is something else that might tip someone over to, so to speak, into a relapse. We don't know what that is. It is possible that it is inflammation. I've certainly anecdotally seen people have a relapse after a major event. But that is an area of active research, particularly for teams in Europe right now. I do not know whether an anti-inflammatory diet would help, but I would be curious to see if my colleagues have thoughts on that.
Yeah, I'd echo what you're saying, and that we with particular attention to diet is so complicated that it's really hard to tease out whether certain parts of the diet are beneficial or not. So it's a much harder sort of scientific question to answer, which is why the nutrition world is very complicated, and we don't have a lot of science. And in fact, a lot of the advice even about healthy eating has changed quite a bit over the last 10 to 15 years. So I think the answer is we don't know. When it comes to treatments that haven't been tested, I think the most important thing is whatever we're trying, that it doesn't cause harm. Obviously, this is an important part of our roles as doctors, is to make sure our patients don't have harm. And so anytime we're trying something, it's important to understand what are the risks of doing something compared to what are the potential benefits. And if something like a anti-inflammatory diet isn't causing any harm to you, then given that there are potential benefits, it may be worth something trying. But we don't have good science yet, and I think hopefully at some point we will. But there is a lot of research going on trying to understand the connection between the immune system and our GI tract, not only in this, in many immune diseases. So I think hopefully at some point we'll have more answers for you.
So here's a good question, just to do it real quick because we're about out of time. Where do you get your plasma from? So where does this plasma that patients get come from?
I can quickly answer. The plasma comes from blood donors. So when people decide to donate their blood, for the most part, we think about donating whole blood. So when we put in an IV and remove about a pint of blood, that pint of blood is a mixture. About half of our blood is cells, mostly red blood cells, hence the red color. And the other half is the liquid part, the plasma. And so each unit of plasma and blood is just that component, that little piece, that piece of the blood. So about half is liquid or plasma and half is blood cells.
Yeah, I would just quickly add to that. There are people who can actually donate just the plasma. So in fact, there are places around that specifically that's what they do. In other words, they request people come in, just like they do blood drives and blood donation drives. They do plasma drives where you can donate just the plasma part of the blood. So that's how we get the plasma.
And that's collected with the same machines that are used to treat TTP, those what we call apheresis machines that spin really fast to separate the two components of the blood.
All right, well, thank you guys so much. I'm going to bring Dr. Spiro Cadlin on. He's going to give a talk about relapse, which has been a very hot topic in the questions. Don't worry, the questions won't go away. I will continue to have them answered throughout the day. It looks like a lot of them have to do with relapse, so they'll be very relevant. Thank you guys for joining us.
Thank you.
Thanks, everyone.
Thank you.
Thank you all.